I'd like to introduce your speaker for this session, Eric Lucas, Managing Director of Moss Adams. With over 2 decades in healthcare finance, Eric leads the provider reimbursement services at Moss Adams and has extensive experience in government reimbursement. He previously served as System VP of Common Spirit Health and is active in the industry, payment work groups, and advocacy efforts. Take it away.
That work? Okay. Well, I know you guys are all settling your food in your stomachs, and I hope that you find this topic a good way to relax with that. I realize that not all of you find Medicare regulatory updates exciting. I will do my best to spice it up as much as I can as we go through it. So. I said it's a IPPS final rule. I basically will be talking about all aspects of Medicare updates, just what we're expecting to see in 2025. And my focus is typically on payment. If we could have a broader conversation about all the quality issues and coding issues, I tend to refrain from that. I'm not good at it. And we have much better people to talk about those issues if you actually do want to care about it. I tend to focus more on the payment side. So in that note, I want to talk about a few things about the IPPS rule. That is, it will start come October 1st, and what's changed there. And I'll tell you the interesting thing, when we go into an election year, you know, I'd been with Common Spirit and Dignity Health for a number of years. And the one thing I would tell the CFOs every single time is, on an election year, every 4 years, nothing's gonna happen. Like, Congress doesn't wanna do anything, CMS doesn't wanna do anything. It's usually a very quiet year, and it's the year after the election that you see massive changes in payment policy. However, CMS was rather interesting on this one because there are a couple things here that actually are rather big changes to things that they've done in the past, and I want to talk a little bit about those as we get into it. But number one, just talk about the payment rate, some changes that occurred with MSDRGs. It's a good place to start, just to help hospitals model how the impacts are going to ultimately affect their hospitals. But then I want to talk about the T model, which is a brand new alternative payment model that is mandatory, will be affecting Oregon hospitals, and is very new in its implementation, and what CMS is trying to do there. Let's talk about wage index. Typically not a big change. This year, there's actually some big change. And so I want to talk a little bit about that. The decreasing reimbursement we're seeing on Medicare DSH and uncompensated care and bad debt, and what is causing some of this, and what we can anticipate going forward. I won't spend a lot of time on it, I'll spend a little bit of time on medical education. I promise not to spend a lot there. A little bit of time on quality programs, and then we have a host of other things in the grab bag that are in the inpatient, rehab, psych, and in the proposed outpatient regs that we'll just kind of touch on as we go through this, and I'm sure I'll have some opportunity for any questions that people have. So everybody's still with me? Okay, awesome, let's do this. Okay, so let's talk about the payment rates first. So the current payment rate is 2.9% finalized. The number of comments to CMS indicating that was completely insufficient was voluminous, including from MedPAC, the organization that provides guidance to Congress about Medicare policy, said, hey, guys, we are in the middle of inflationary pressures that are impacting healthcare a little bit more than some other industries, and we haven't really adjusted for this. And CMS decided that, in its infinite wisdom, that it was unnecessary. They came in with a 2.9% increase. If you've been doing this for a while, it's pretty much what they always come in at. Like 3% is the pretty average that we've seen for the last 20 years. So it's a little surprising. Last year was 3.1%. The year before, it was around 4%, was the only year that they did anything to kind of inflate it, for some of those pressures, but really has not adjusted for what the industry is seeing from inflation, as we see when we start doing the analysis of where costs are going and where Medicare reimbursement growing. That gap continues to grow year over year, as it has since the Affordable Care Act was passed. Okay, so what does that look like? They're essentially saying that overall it's going to be a 2.9% increase for the standard hospital. It's lower if that hospital is not submitting its quality data or is demonstrating that it's a meaningful user. So you can see that a hospital that is not doing quality data or meaningful user is actually seeing a payment reduction year over year until they get on board with that. The 2.9% includes a market basket update of 3.4%, which is the historical average that they were expecting at this time, less the productivity adjustment that was introduced in the Affordable Care Act. So to try to overcomplicate this, because that's what you want at the top of a presentation like this, is to overcomplicate it. This is essentially the layout of the IPPS payment. And I want to kind of break this down a little bit and talk about, number one, how this payment rate fits in. And so in this case, we're going to start talking about the labor and the non-labor portions of the operating payment base rate. And then we're going to jump over to the wage index in a second. So thinking about that, we have a $7,117 payment rate. And that's broken down between labor, non-labor, and capital. The important piece there is the labor piece will be adjusted for geography, as will the capital. The non-labor will not. And so, and in the markets where the wage index, or the average hourly wage above the national mean, is above 1, it's 67% of that rate will be labor. And if you're below that 1, it's 62% less adjusted by it, and therefore less deflationary. Now, as you can see there, the rate change from 2004 is not the 2.9% I talked about earlier. That's just the flat payment rate. And to overcomplicate it, it's just a small piece of the puzzle of what's going to ultimately impact the amounts that hospitals are going to get. And this is, I promise I won't keep doing this. This is where it gets really complicated, because in order to get from that 2.9 down to that 1.67, they have to do a ton of adjustments to make everything budget neutral. And so an example of that is CMS says, okay, 5% of the total, 5.1% of the total amount that we're going to pay out is reserved for outlier payments. And so they got to back that piece out. So if you look down there, operating outlier payments, 94.9%. So they're backing that amount out and paying that separately. Every single one of these is adjusting for some policy where they've carved amounts out to directly assign them a different way, and therefore have to back those out of the overall payment rate to get down to what we talked about earlier. Here's the capital rate. Nothing, it's a little bit easier to swallow than the other one. So speaking of outliers, it's another issue that seems to not, or seems to be getting impacted a little bit differently than what we expect. Year over year, CMS tries to estimate where they think outliers are going to ultimately pay out at. Because they have 5.1%, and they don't go back the next year and adjust their outliers because they went over or under. If they miss their target, it's like, oops, we got to change our policy and fix it the next year. It's a loss. And so we had a number of years back in the early 2000s where they just underpaid year over year, and we all screamed like, what are you doing? Like, you got to pay this out. And they're like, we're trying, we're doing our best. And we appealed, and they said, you can't appeal that. But we will improve. And then we had a couple of years where they went over. The last few years, they continue to have gone over. And every year, they've adjusted the threshold significantly. So for the last 3 years, we've seen big jumps up in the threshold to determine what is going to be an outlier payment. And in this current year, we're seeing another big increase. They came out and they changed the process again to try to get it right after they had changed the process last year and the year before. But they've changed it again. They think that they've got it now. But in the same time, we have an 8% increase to the overall threshold. So hospitals that aren't increasing their charge rates at a similar rate probably are seeing their outliers declining relative to their peers. This will impact all cost reports after October 2024 or years after October 2024. Oh, I'm sorry, I just jumped ahead. They introduced a new outlier reconciliation process. So I don't know if you're been around like me, you might remember a long time ago when hospitals were using outlier policy to actually get better reimbursement. And I'm not going to name any names. Some people got in a lot of trouble. Because they were getting their rates set and then raising their charges, and therefore getting higher outlier payments. And so if you timed it right, it could work out really well for you. So they introduced this outlier reconciliation to basically say, you're not going to get overpaid. If something happens, we're going to identify it and do a reconciliation and pull that money back. Or if you were underpaid because of something that happened, like you lowered your charge rates, we'll add additional payments. And they hadn't really been utilizing it except in really extreme situations. But they essentially came back and said, no, we really need to do this. We need to do a better job of it. And we're going to ask our MACs to really step this up and start applying it whenever we have outliers above $500,000 and a 20% change to the cost of charge ratio on all hospital cost reports starting after October 2024 and any new hospitals. So we will probably start seeing a lot more of these outlier reconciliations occurring. And as a result, they actually, from the proposed outlier threshold, brought the threshold down a little bit, saying, yeah, we're going to recoup some money from this new policy. So we actually are going to estimate that we don't have to set the threshold quite so high to get outliers at that 5.1%. See, spicy, getting there. Okay, so MSDRGs, not a big change here. They use the 2023 MedPARK claims, the 22 cost report. Well, I guess what's interesting there is we've kind of got through most of the COVID years now, which were really making a lot of weird trends in the numbers, and they were causing CMS to have to make some adjustments to ultimately come up with a MSDRG weight set. They did not have to do that. They did not introduce many material changes to the MSDRGs. There's 12 new MSDRGs, and there's 5 that are expired that are essentially related to the 12. So it's fairly straightforward. The one thing that I would point out is if your hospital is going to do any analysis, one analysis that you might want to do is just to compare your current payments or your current service mix with the new MSDRG weights and see how much of an impact it is. There is a lot of fluctuation with the MSDRG weights this year. There's 40 that increased above 5 to 10%. There's 27 that are more than 10%, some of them significantly more than 10%, and some of them are common DRGs. And there's 47 that are decreasing between 5 to 10%, and 31 that have decreased by 10%. And if you don't know, because of all of this fluctuation from year to year, CMS had introduced a cap. So no DRG can fall below 10%. Their weight can't fall below 10% of the previous year. So you could actually go out there and say, okay, well, this one looks like it's got another 30% to go down. So for the next 3 years, I could expect that this is going to continue to decline in reimbursement year over year, because you can see how that trending is working out. So some of the larger weight gain or relative weight gains are listed here. As you can see, pancreatic transplant at 63%, arthroscopy at 28.58%. So a couple here that are pretty significant increases to the relative weights relative to 2024. Okay. Grouper software has been updated to 42. Medicare or CMS introduced a new severity DRG policy that was going to really significantly change how they were breaking out the comorbidity, major comorbidity, no comorbidity breakout in the current DRG set. It would have changed the weights all over the place. This was introduced in 2020. They didn't want to do that in 2020 because of COVID. But every year since then, the comments have been, hold on a second, you need to give us more data, we need to understand this. And every year CMS has come back and said, you're right, we're gonna keep looking at this, we're gonna keep fumbling around with this, and we'll get data out so that the hospital community can actually look at this. So it's definitely an area to watch because we could see some pretty significant change similar to when they first introduced the MSDRGs. They did introduce 9 guiding principles last year to determine how they're going to assign the CC and major comorbidity and major comorbidity, and they applied it for the first time this year. I had memorized them last time I did this presentation, and I've completely forgot them already. But if anybody's interested, I'll be happy to look them up and get those 9 guiding principles. And then the only real change to diagnosis codes, and we're going to talk a little bit about it later, is for social determinants of health, which gives an opportunity for some additional reimbursement to hospitals, which I'll explain when we get to that slide. New technology add-on payments, there's not really a lot of change here. They've added, or they're continuing to use 24 of previously approved technologies and discontinuing 7. There's 5 under the traditional pathways and 12 under the alternative. The only thing that they've really changed here is the process of determining what will be added to the list and the timing of when it can be added to the list and how the approval process with the FDA weighs into that process, because there was always a timing problem that created a conflict, and they've tried to address that to make it, to expedite. Okay, so now let's talk about something new, the T model. So this is a little surprising because this is an alternative payment model. And if you've been following CMS for the last 10 years, they've really been talking about revolutionizing fee-for-service and into more value-based care. And they've introduced a lot of different ways, and for the longest time it kind of looked like Medicare Advantage was going to be their efforts, and then they slowly started introducing these bundle payment programs and the ACOs. And some of them have been successful, a lot of them have not. And so, but they're going to continue to do it. We had CMS on a webcast, I want to say a year ago, talking about these things, and they are very gung-ho to keep, finding ways to expand the way fee-for-service approaches care in reimbursement. So they introduced the transforming episode accountability model and in the current year. And what's different about this is it's mandatory. Not for everybody. There's about 30 pages in the regs that explain how they came up with the hospitals that will be included in this program. It's based on geographic location, and everybody within a geographic location that's identified has to mandatorily participate in this program. And that's unique. They've never done that before. CMS has made it clear that they're looking at this program as kind of the future for all the upcoming programs for alternative payments. So this is really going to get a lot of attention and focus. Right now, the way they did this, they identified CBSAs, core-based statistical areas, the census number. It is, in Medicare, we've used the CBSAs for wage index purposes for labor markets. This is a little different because for wage index, we took the core base statistical areas and we actually used the breakouts, the micro markets within those. This doesn't do that. This is looking at the entire CBSA and essentially saying, okay, everybody within that market will be participating in this program. Hospitals that are already in the bundle payment program or the CJR may voluntarily opt in regardless of where they're located. The process for that is still vague. It's going to be around January 2025 through a letter of intent. We expect that there's going to be a lot more details that come out about that. Excuse me, let me get my notes because there's just too much that I don't want to lose. So the goal here, of course, with all of these programs, reduce costs to the Medicare program and improve quality and patient outcomes, right? Like that when they've approached all of these, that is the criteria here. There is a requirement to have the patients refer back to primary care to reduce the fragmentation, to align the care, improve the care transitions, but ultimately to reduce readmissions back to the hospital, where they see a lot of the cost improvements should be made through that and the improvement through the transitions throughout the care. This program begins January 2026 and it'll run for 5 years. So we have time, it's 12, 13, 14 months to ultimately do this and get it up to speed, which will be necessary because all the details aren't even available yet. So right now, hospitals know that they're going to have to do it. They'll know some basics, but this will affect only the Medicare fee-for-service. And then the question that I keep getting asked is, okay, well, how is this going to ultimately affect how we bill and get paid? And with all these programs, it's pretty much the same. You'll bill fee-for-service as usual. The difference here is they're going to set a target price for 30-day episode of care, and then that will be used in the aggregate to see how the hospital ultimately ended up, or that episode ultimately ended up, to determine if some of those reimbursements need to be sent back to CMS or if they'll be incentivized because they saved money. In the meantime, they're also going to be looking at the quality scores to determine incentive payments. So there's a couple moving parts to ultimately determine how this will weigh out, and we'll talk a little bit more about that in a second. The target price will be risk adjusted, so there will be adjustments for social risk score if there's a high level of Medicare, Medicaid payers, if there is a large homeless population, if there's something other that where there's a demonstrated increased use of resource in services, that will be included in the target price to ultimately do this. And there are 5 surgical procedures that are included in this process. So the lower extremity joint replacement, the surgical hip femur fracture treatment, spinal fusion, coronary artery bypass graft, CABG, or major bowel procedure. They will be looking for an anchor stay to set that 30-day episode. That anchor stay could be an inpatient stay, so the discharge or the inpatient stay admit, or an outpatient procedure to anchor that, and that sets the 30-day period. And then it's all treatment within that 30 days. So the physicians, the rehab, the SNF, the psych, all of it, all gets included in that overall episode. So the expectation here is that all of this care will be coordinated, and they really are looking at the hospitals to be the source of all of this coordination, which is something they didn't say as specifically in past programs. Oops. Okay, so how are they going to do this? There's 3 different tracks for how this is going to be rolled out. Track 1, track 2, and track 3. Track 1, there's no downside risk. You go over your targets, it's fine, but if you actually are able to save money and get the quality scores, your reward for that will be minimal. They're going to allow the rural and safety net hospitals, which tried to get an exemption from this and were told that they would not be able to, but they will be able to stay within track 1 for the first 3 years of this 5-year program, if they so choose. All other hospitals will be expected to actually move to track 3 as quickly as possible. Track 3 is high risk, high reward. And they can qualify for the advanced APM if they continue to use the healthcare information technology and submit their data electronically. So an opportunity for even additional payments. The quality measures that they're really focusing on here, as you would expect, readmissions, patient safety, and patient reported outcomes. And they've added this new thing, the Decarbonization and Resilience Initiative, which is a voluntary report metric. There's no additional payment at this time related to this. This is for hospitals that want to report on greenhouse gas emissions, and there's all these different subcategories for hospitals to use for that type of reporting. If they so choose to do that under this TEAM program, there will be public recognition included, but more importantly, there will be technical assistance and resources provided by CMS and other federal institutions. The thinking here, though, as you would expect, is this is an introduction of something that actually might be something that's mandatory in the future. And so if you want to get a head start, this is a really good way to get a head start on it. The patient outcomes, the quality measures, the patient reported outcomes is really focused on the lower extremity joint replacement only. That would be and the other 2 would affect all 5 of those. So not to overcomplicate that point. So what do you need to do? Number 1, figure out if you're in it. I'm going to show you a map on the next slide if you're not sure. Hospitals there's quite a lot of resources now of hospitals and systems that have gone through all the other alternative payment models. So there's a lot of learning there. Happy to have conversations. We have people who do this quite a lot if you're interested in talking to somebody. The most important thing is to get coordinated with all of the different service providers that will see these patients. I should probably point out something before I get here, because you could have a situation where a patient is already in an ACO, not even one of your ACOs, but if they are in your ACO, that's even better, because you could get the benefit from that patient in the ACO and in this. It's like a double. It's like an opportunity to get additional incentives off of one episode of care. Plus, you could have somebody who's in an ACO for a hospital across town. They come in to your episodes through this process, and it gives you an opportunity to actually get some additional incentive off a patient that's in a separate program. So kind of unique. We haven't seen anything quite like that, and might create some new coordination opportunities. So anyway, speaking of which, getting not only the players within the hospital, getting your finance team and your quality team, your analytics team, your managed care and payer team, and most importantly, your clinical team, all focused on how to manage these episodes in the most efficient way, to look at the data as it's coming in, because there's quite a lot of it, and start to learn and educate everybody along that process, and then starting to coordinate with those outside of the hospital that you have relationships with that actually move these patients through their care along this episode. For those hospitals that are currently in one of the alternative payment models, you probably have already seen that CMS provides a lot of benchmarking data. I've heard some people say it's too much to understand. There's just a lot there, which I get, but they want to be as transparent as possible. But that means that hospitals that have already gone down this road actually have a little bit of data to help them look at this. It's not quite the same because the other programs are 90-day and this is a 30-day, but it's definitely directional and can kind of give you an idea of where you might want to be focusing your efforts as you implement this program. Coming up with an operational plan, doing service line optimizations, all important, but more than, for me anyway, is getting the data and actually starting to go through the data and understand it in a way to know where your weaknesses are and where you need to focus your attention. I honestly thought I'd lose more than one by now, so. Okay, so who's in? Before I even started talking about this, did anybody know that they were already in this? You knew? Okay. Anybody else? No. Okay, so 3 CBSAs within Oregon have been selected for this. I've heard enough people say that this is a random selection. It's not a random selection. I mean, they came up with a pool that there's a little bit of randomization, but CMS knew what it wanted to do here. And just so we're clear that they've selected about 40% of the hospitals. It's like there's a lot of hospitals that have been selected through this. Actually, that's 30%. It's 748 hospitals, I think, have been ultimately selected. So in Oregon, it's the Portland, Vancouver, Hillsborough CBSA. So not to be confused with the Metropolitan Statistical Area, which is what you use for wage index reporting, which only includes Portland, Vancouver, and Salem. This is the entire CBSA that's outlined there in black. So it goes pretty far down. And then Bend, which I believe we're in now, right? Close. Is it in the same CBSA? Oh, maybe not, okay. And then the Klamath Falls. I love that area. So it's a big part of the hospitals within Oregon have been selected for this program. So maybe I'll stop there for a second. Do you have any questions about team?
On the map, is it just the areas that are bold up where you've got Portland, Vancouver,
Yeah, it's pretty awful. I took this from the census. It is this area down to here. Yeah. Yeah, it's really awful.
So where it says Bend, Prineville, is it also including to the left of that? Oh, sorry. Is it also including to the left of that?
This right here? It
Yes.
is. Yeah, this is the entire CBSA.
Okay, gotcha.
This is the Micropolitan Statistical, this is the CBSA. Yeah. Oh.
Eric, so the Klamath Falls, that's only one hospital?
Is it really?
That would only be the Sky Lakes Hospital.
And there wasn't any requirement when you look at the rules about what they were selecting, because some of the comments in the proposed rules were like, well, you're going to exclude the CBSAs with safety nets. And they're like, nope. You're going to exclude the ones that just have a critical access hospital. Nope. Like that, they were pretty clear that wasn't their approach. They really wanted to see how this would work in a variety of markets. And they don't really want to focus on just specific urban areas or specific rural. It's really a mix of all of those. So if there's one hospital, there's one hospital. Is there another one?
Oh, on CMS, there's a list.
Yeah.
Excel spreadsheet.
Funny enough, they just came out with that like a week and a half ago.
Oh, really?
Yeah. And what was funny is we did a webcast, and every comment, we had like 900 people on this thing, and all you could see is, are we included? Are we included? Are we included? Are we included? And I think part of the problem is, if you're a reimbursement person, you're familiar with CBSAs, but the CBSAs that they're using for these labor markets is different in a lot of places than what they're using for this. I mean, not just where the boundaries are. So it's made it a little bit of confusing, and then the questions were coming up, well, what if we reclassify into one of these areas for wage index purposes? And it's like, slow down, it's geographically, are you in one of these areas? Okay, so let's get back to more fun stuff. So we talked earlier about splitting out the labor and the non-labor pieces. Am I doing it on time? Okay. Now we have how we're going to adjust by a geographic factor. So we're going to start with talking about the wage index. And for those of you who don't know, the Medicare cost report includes a lot of information to help calculate an average hourly wage for the hospital. That is aggregated to come up with wage index factors. And to that end, there's not really anything different about it in the current year. They're using FY21 submitted cost reports. If a hospital does not submit their information, or if it just looks wrong, they will just remove it or put a proxy in and tell the hospital to fix it next time. This is a little of a weird year because CMS acknowledges that they know that there's COVID stuff in here, and they feel like they still have the information they need to do a wage index average, and note that there is some limitations because we do a 3-year average to stop it from getting too volatile. And CMS admits they actually have no idea how COVID has impacted wage index and haven't really finished any studies related to it. So wage index this is kind of an interesting issue because this has been a concern for like 20 years. Like the wage index is, it has a massive impact on the Medicare payment. You know, it impacts inpatient and outpatient and all the other payments, this factor that's being applied. And there's a lot of concerns about how that's impacting hospitals on the lower end of that scale. And so there's every year this push to look at other factors other than the cost report to set this. You know, and in my last organization, we would fight those all the time because it just put everything in a black box and made us really scared about how this all works. But it seems that CMS has kind of died down from that, and MedPAC isn't really suggesting anything right now. We don't really hear a lot of that, and part of that is because they've started to make all these other adjustments to kind of placate the people that had concerns. So first of all, in looking at this current factor, one of the things that makes this year new is that every hospital, every 3 years, has to file an occupational mix survey, basically to determine the impact of your average hourly wage based on clinical care. And this is the first year of this latest survey. And it does have a slight effect on how these numbers ultimately change. I mean, the unadjusted national average is $55 an hour. When we apply the occupational mix, it changes to $55.97. So, and as you can see, we were talking earlier about the inflationary. Their own data is showing that there's an 8.7% increase to the average hourly wage nationally, and yet our overall increase is 2.9%. So, okay, so here are the wage index factors for 2025. And you can see where those factors are moving in most cases, and Oregon is actually pretty rare here. They're increasing year over year. This is the average hourly wage from the previous year. That's not what's weird. This is what's weird. This is the actual wage index factor. So a lot of the conversations that I've been having with people is saying, well, our average hourly wage went up. It went up like 3% or 4%, but my wage index is going down. It's 'cause, well, national averages is going up pretty fast in a lot of these markets. So as you can see in Oregon, that seems to actually, wages have exceeded the growth rate of the national average. And so you're seeing a pretty big increase in most of the Oregon hospitals. And if a hospital's reclassing, it's not quite as clear. There's some blending that goes on, and I didn't get into any of that. So, and in most cases, most hospitals are at the rural floor anyway, so. Okay. Portland was not going down. Oh, Portland is going down. Yeah. Well, somebody's going down. Portland and Eugene. Yuck. So one of the biggest changes that they made, and it's kind of affecting Oregon, not as much as others, is there was a change to those that CBSA map. The Census Bureau changed where those lines were that essentially determine where rural and urban markets start and stop. And they made a big change, and they hadn't adjusted it until this year. They essentially made a change to finalize the proposal to change where the CBSA delineations start and stop. And what's interesting about that is there's so many factors that rely on whether a hospital is urban and rural. It can determine what type of hospital you're allowed to be or how payments are going to get made. So moving from rural to urban or urban to rural could have a impact on not only how that hospital is supposed to be operating, but how it's supposed to be paid, what it's expected from quality measures, et cetera, et cetera. So there are 53 counties currently urban that will become rural next year based on these new delineations. And therefore, those hospitals will go from being urban down into the rural floor, which changed how that rural floor was being calculated. And then there are 54 counties currently rural that will become urban, impacting 24 hospitals. And these are hospitals that were urban that could now be faced with concerns about whether they could still be critical access hospitals or sole community hospitals, and we'll have some work to do to make sure that they are continuing to get the payments that they expect to get here. And so there is some transitional timing here to make it so hospitals aren't going to fall off a cliff in a couple months because all of a sudden they're moving from urban to rural or rural to urban. And so there is a little bit of a leeway, but hospitals will need to take some action. So for Oregon, no urban counties moved to rural, but there are 2 rural counties that moved to urban. And I don't know if there are hospitals in these particular markets. Jefferson moved to Bend, Crook moved to Bend. So in those particular cases, if you have a critical access hospital and you're slated to become urban, then you have a concern about your critical access hospital status because being rural is part of the requirements there. And if you have sole community hospital status or Medicare dependent status, the requirements are different depending on whether you're rural or urban. So there are some steps that hospitals can take. One of them would be to geographically reclassify. You can redesignate yourself as you can't do this for team. Team is, you can't say like, I don't want to be in this market anymore, I want to be in that market. But for the purposes, and it's not even a secret anymore, there are hospitals within major urban areas that are designated as rural. And there are rural hospitals that redesignate as urban. Surprisingly, hospitals like in the middle of Phoenix are designated as rural, and Southern California, LA, be designated as rural. So there are reimbursement opportunities for doing some of these things, and those opportunities are just as available here if your hospital has any risks because of these changes to the CBSA. Okay, So one of those provisions I talked about earlier to stop hospitals from complaining about the wage index was the low wage index hospital policy, which essentially said, okay, well, if you're the bottom quartile of the average hourly wage, we're going to bump you up. And the thinking here at the time was that there was a wage death spiral. That what was happening is these hospitals were seeing lower and lower Medicare reimbursement because their wage index shrunk year after year. And so they couldn't raise the salaries of their teams. So CMS said, look, what we're going to do is we're going to create this policy, give you an opportunity to get these higher reimbursement rates and increase your salary. This was supposed to be, or this last year was supposed to be the last year of this program. And CMS came out and said, well, the problem here is that this whole thing ran over the COVID years. And we don't really understand how COVID impacted this because everybody saw their nursing salaries go up. And so we had to start over again. And so they're now saying, okay, we're going to start this over again in 2025 and go through 2027. And so the program has been extended further. But this is complicated by the fact that the other hospitals, not inside the 25th percentile, sued. And under that Bridgeport Hospital versus Becerra case, those hospitals won. And their problem was, well, there was nothing that required you to offset our reimbursement to help these hospitals. You should have just bumped them up and not made it a budget neutral adjustment. And so the hospitals won. And CMS appealed. And just in the last month, like as a day before they released the final regs, they lost again. And they lost, and the courts, the appeal court basically said, you have to pay interest, you have to change this policy. And CMS said, well, we still have options here. We can ask for the entire, we can do an bank, ask for the entire appeals court to weigh in, or we can try to appeal this to the Supreme Court. We don't know what we're going to do yet, so as for now, we're just going to go forward with this policy. So this could see another change overall to how hospitals are paid starting in a few weeks. Okay. My God, I talk too much. Okay. So let's talk about uncompensated care. And I'll try not to be as boring with this one. So one of the questions that I get asked all the time is why the Medicare uncompensated care dollars fluctuate so much from year to year. Why can't they just budget what they used last year? Because every year that number just has been going. In some years it goes up, in some years it goes down. And so let me try to explain just real quickly as to what's going on. But in this current year, so I hate this chart. I'm going to go to this one. So in the current, there's three factors that determine how much a hospital is going to get from Medicare uncompensated care. And let me weigh in. The one thing I'd say about this particular topic is it seems like every state is starting to use this data for their own uncompensated care. And I'm not saying Oregon is going to do that, but it seems like every week a new state is saying, why don't we just use S10, which is where this information is. And so I think it's a good thing to make sure that you know what's on your S10 schedule. And so in this particular year, there's three factors that we want to look at. Factor one, which is let's estimate what we expect the total dish payments, like traditional dish payments, are going to be. Then there's factor two, let's adjust that for the patients that are moving to an insured product. And then factor three, which is the hospital-specific percentage of that pool. In this particular year, they expected slight increases to factor one in the current year from the previous year. So it's going from 10 million up to 10.5 million. So they expected that there would be some increase to Medicare DSH. And so you could see where they proposed and where they ultimately ended up. This is for factor two. You can see where they proposed and ultimately ended up. this has been probably the most debated part here. They tend to come pretty close on factor one, but factor two is somewhat concerning because we know the patients are moving out of Medicaid because of redeterminations, and so we're seeing bad debts increasing. We're seeing charity increasing in a lot of markets. So, what is going on with the uninsured population? How is it changing, and how is it changing in correlation with the base year, which is in 2013? And so you can see that the uninsured level, it continues to be, in this year, increasing slightly, to ultimately get to a final amount of 5.7 million distributed to 2,400 hospitals. So they had proposed just a few months ago that pool was going to be 6.5 billion, and it ended up being 5.7 billion. That's a massive reduction between the proposed regs and the final regs, especially when you consider that $1 billion difference or $700 million difference is distributed amongst the 2,400 hospitals that are within that pool. This is what the pool has been doing year over year. And you can see, in some years we have massive growth, and this usually is because of, in 2019 and 2020 was because Medicaid was growing year over year because of redeterminations, or because of the policies related to the PHE. And then as they've slowly moved folks out of Medicaid, we're seeing that number go down yet again. I'll tell you, during the Affordable Care Act, we were kind of sure that this was going to be the first step in getting rid of these dish payments altogether into something completely different, but it continues to have a life. They use a 3-year average here. Because of COVID, they've had to make adjustments to a 2-year average. They'll go back to a 3-year average here. And there's some changes to the cost report S10 that could actually have a pretty big difference, a pretty big change here as we go forward. One of the things that we want to talk about here is what we're seeing from audits between what hospitals are filing and what's ultimately ending up in the results, because not only is there fluctuation in factor one and factor two, but we're actually seeing a lot of variation in factor three, which is the hospital-specific rate. And in this case, we can see that in 2021, which was the last year for the of audit, you had 2,400 providers. 2,135 of those had a change to their uncompensated care number on the cost report for a $1 billion reduction in uncompensated care. So this is a big area that the MACs are focusing on. This breaks it down between the uninsured and insured. As you can see, the uninsured's going up. The insured is going down. The reason that's bad is because the insured is dollar for dollar. The uninsured gets applied a ratio of cost to charge to it. So you really want you really don't want to lose your insured. And that really is because hospitals are having a hard time identifying their deductibles and co-insurance within their own data when they're doing their compilation work here. But we're still seeing billions of dollars changing from filing to final. And then what we really have been focusing on is how bad debt is changing, because we have been seeing some growth in bad debt. And this is an area that is getting a lot more review. We're used to seeing Medicare bad debt being reviewed from a reimbursement element because the MACs have been focused on it for a long time. But in the S10, they hadn't really been looking at it very much, and now they have definitely moved the goalposts a bit. They're spending a lot more time on this area, ensuring that the bad debt is aligning with the policies, and so hospitals really need to take some time to make sure that their bad debt that they're reporting on this will fall within the lines of their own collection policies. So I talked a little bit about Medicaid redeterminations, and Oregon's, I think, pretty far along. I think you guys are wrapped up your redeterminations here. But it's still having a lot of ramification for a lot of my clients because we've had such a shifting in payer mix. From 2019, 2020, 2021, states couldn't remove anybody from the Medicaid enrollment numbers. And so a lot of hospitals put their started 340B programs or other programs that rely on those Medicaid numbers, provider fees or state dish. They were relying on those things, and now all of a sudden they're seeing their Medicaid numbers go down. There's shifting occurring, and they're asking, well, what exactly happened? And so it's really just understanding that we're returning not necessarily just to 2019, but we're definitely going to a pre-COVID payer mix, and we're probably seeing continued decline in that area and seeing more moving into the exchange or into because of some of the job numbers we're seeing people in plans through employers.
Hey, Eric.
Mm-hmm.
Oregon is, I think, second or third for the least amount of folks that drop off of Medicaid, but we still haven't seen a huge number drop off. We've seen some.
Do we know why? I tend to focus on states that dropped significantly and not spend a lot of time on states that.
Somebody else might know better. I think it's second or third country for the least amount of folks, percentage-wise, that have dropped off.
So they weren't as aggressive in their process.
Not to be, there's also a bridge program.
Okay.
Folks that usually drop off that.
That would definitely help because I tell you the thing that we're doing a lot of right now is a lot of strategy work to maintain 340B qualifications because once you get into a 340B program, you don't really want to lose all the work you put into it and the savings that you get out of it. So you start to wonder, okay, well, what can we do to continue to meet the thresholds and stay within this program? I'm running out of time, so I'm gonna. I talked a little bit about bad debt. I point out the Medicare bad debt was selected by the OIG for additional audit. There was concern that they're over reimbursing for Medicare bad debt, which they've been saying for like 30 years. And they're back with another one. They did another sample, and they came back and said, yeah, we still are finding some pretty big variation of hospitals that couldn't support the amounts that they're reporting in their cost report, or where they don't have the collection effort that meets the needs, or their write-off for their indigent care is not meeting policy or consistent with regulations. And they submitted the findings to CMS, and CMS was like, you're right. We are changing our approach. And so any day now, we're probably going to see some instructions going out to the MAC on how they're going to make those already very difficult audits even more difficult. And I think this is probably one of those final areas where they're very difficult to get a bad debt approved without having all your P's in order. And which kind of takes me back to here. They made a major change to the cost report. This is like the first year of it, where they have started to request more data to support the amounts that are reported for Medicare bad debt and DISH. And you see, usually you'd submit your cost report, there was some data you had to provide, but now all of the data that they would expect at time of audit, plus some additional fields, are now expected to be submitted with the cost report, or you could be on payment withhold. And it's clear when you look at this data that the real approach of this is going to be to improve the audit process related to them. because they have all of the data to actually do much more expeditious evaluations of the amounts. They also added a field on a form on Medicare uncompensated care where they broke out the hospital, the whole total hospital, from just the acute inpatient side. And the idea there is they're going to move that process away from a hospital to very inpatient specific adjustment in the near future. Okay, GME, I just want to point out that the Consolidation Act included more slots for teaching hospitals. Half of those have to go to psychiatry or psychiatry subspecialties. The way they're doing this is to try to break it out between rural hospitals and states that have expanded with expanded medical schools, or hospitals in a HPSA market, or hospitals currently exceeding the limit, but they want to actually allocate to all of those separately so that there's not one getting too much, and they want to also ensure that no hospital gets more than it ultimately should. They really want to spread this out as much as possible to the hospitals that they feel that believe they need the additional slots. This is the second program. So I get the question like, well, wait a second, didn't they just do this? Yeah, this is another one. They're gonna, they did this in the 2021 CCA, and now they're doing it again in this one. Okay, I'm not going to talk about a lot of quality measures. The only thing I would point out is in the quality reporting, the one thing that really is changing this time is related to patient safety measures. We're going to continue to see more in that area. As far as it relates to value-based payments, we have the hospital equity adjustment that was introduced last year. That's going to be added to the VBP scores, and then we have no change to the hospital-acquired conditions or readmissions, but there is some pretty big changes to the HCAHPS, the patient surveys. They're going to start introducing those changes now. It's not going to affect value-based scores for a couple of years until those feed through, but there's a number of new fields that are being added to the patient surveys. Okay, so I mentioned earlier social determinants of health diagnosis codes. These are codes that identify patients that are homeless or that are in, what is the word? Have home issues. There's a better word for it. I'm missing it right now. But these codes will actually move a case from a non-comorbidity to a comorbidity, therefore increasing the reimbursement on those, recognizing that these patients actually require more resource usage. And so, they introduced this last year, they expanded it this year, and the message from CMS was, hey, we want to do a lot more here. Like, if you have ideas, if you have patients, patient groups in this social determinant of health kind of bucket, where you think there's additional resource use needs, let us know. This is an area that we want to start to move the fee-for-service program into. Okay, long-term care, acute care hospital increased their rates by 3%. They introduced a additional IPPS payment for buffer stocks of essential medicines. The way that works is you have to be a hospital that is not in a system, and you have to have 100 or fewer beds. And if you do that, the cost of maintaining these buffer stocks, and not all of the details of what that looks like yet have been released, but I expect them any day now. But those costs would be reimbursed through the cost report. Those additional payments would be reimbursed as long as you maintained, I think it's a 6-month stock of specific medicines identified. The Medicare Dependent Hospital Program is set to expire at the end of this year. That's because it's been one of those things that every time they would do a new appropriations bill, they would just push it out a year, and then they just stop pushing it out a year. So I know something passed yesterday. I didn't see if it included an expansion to this. And so this could be the end of an additional payment for these hospitals that are Medicare dependent hospitals. At the same time, the low volume hospital add-on payment, which I know there's Oregon hospitals that benefit from this. The criteria had always been pretty low, so hospitals couldn't really qualify for this unless they were, the numbers were for really small hospitals. They expanded this program. But again, it was one of those things that was only getting approved year after year, and it has not been approved, at least not that I'm aware of. And so the old criteria is going to come back into play. Okay, rehab rules, the increase is the result of is 3%, seems to be the standard, 3%. It's 3.5% market basket increase less the 0.5. As with some of the other areas that I mentioned before, there is payment adjustments between urban and rural. If those impact this because of the CBSA changes, there is a transition to ensure that the drop is not significant year to year. They made a pretty big change to the outlier threshold here, as they did with the acute side, which is significant and will definitely change payments and how they're flowing through. So the overall economic impact is $280 million in increased payments, which is $300 million because of the rate increase, less $20 million from the outlier threshold update. Psych is kind of the same situation where we're looking at 2.8%. It's, again, because of the CBSA change. There is a factor there to prevent them from losing too much because of the rural adjustment. And then there's some patient-level adjustment factors that have finally been updated that hadn't been updated for quite some time. And then the outpatient regs are still proposed. The comment ending was the beginning of September. And so we won't see the outpatient rules come out until the beginning of November. What's interesting is the last few years, it really has been outpatient where I think they've tried to sneak in some pretty big changes. This year, not so much. This is pretty standard rate increase. They're not doing anything they're not expanding site neutrality as we were expecting them to do. There's no further tweaks to 340B hospitals. It's pretty standard type stuff. So I'll stop there and open up for any questions. And some water. Spicy.
So we are very much impacted by the rule to urban status with our critical access hospitals. Do you know why that happened and what the criteria might be?
It literally was just aligning federal policies. So they were taking the Census Bureau's delineations and applying them to Medicare. They do it not often. I think but they do it like every decade.
Okay, thank you.
But there are options.
Yeah.
So there are definitely options. So yeah, definitely take advantage of those. Okay. That's good. I don't think I could talk anymore, so I kind of hit my limit. Thank you.
Thank you very much for that great session.